Good afternoon. My name's David Cashin and I'm the Product Manager for Emergency Care and Resuscitation at Philips Healthcare. I'd like to welcome you all to today's webinar, which is conducted in partnership with the Council of Ambulance Authorities. It's great to see we have over 200 attendees today at this webinar, and I'd also like to welcome our international guests as well for joining us today. Just some housekeeping items before we start. All attendees will be on mute to avoid any disturbance during the webinar. Questions, we will have a question and answer section at the end of the webinar, at the end of the presentation, but you can post your questions on the right-hand side of the screen anytime during the presentation. And you can be anonymous as well by ticking the anonymous box. Recording, so the webinar will be recorded and it will be available after the webinar via email once it's ready. And just one disclaimer, this presentation by Professor Richard Lyon has been prepared independently, so it's his own presentation. What I'd like to do first of all is start off by introducing Dave Walters. So David is the CEO of the Council of Ambulance Authorities, which provides leadership for ambulance services in each state and territory of Australia and New Zealand. The board of CAA consists of the chief executives for each member service. David also fulfills the secretariat function for the Global Resuscitation Alliance and represents the ambulance sector of a number of national and international boards. So I'd like to hand over to Dave Waters.
Thanks, Dave. It's very nice to see you during these complex and difficult times under COVID. So on behalf of the CAA, can I welcome all our attendees to what is our first co-hosted webinar with our good friends from Philips and the Council of Ambulance Authorities. We are really excited to partner with Philips on this first webinar in our 2020 Knowledge Series. And we're going to bring, as a start, a fascinating speaker whom we've had the privilege to host at our CAA Congress last year in Perth. Our presenter today is Professor Richard Lyon, MBE. Professor Lyon is an active consultant in emergency medicine and pre-hospital care and the Associate Medical Director for Air Ambulance in Kent, Sussex. Prof Lyon holds a personal chair of pre-hospital emergency care at the University of Surrey and has been honoured by Her Majesty the Queen for his services to emergency healthcare. Prof Lyon has an established research portfolio in pre-hospital resuscitation, trauma care and emergency medicine, with an extensive publication record. He's won numerous international awards, including the Top Research Award from the European Resuscitation Council. As we know, Richard has a special interest in pre-hospital resuscitation and trauma care. And today, Professor Lyon will be speaking to us on the management of traumatic cardiac arrest with the aim to improve clinical outcomes and maximize survival of our patients. As we know, traumatic cardiac arrest is one of the most urgent, time-critical and life-threatening trauma situations EMS teams can face. And understanding the management of traumatic cardiac arrest has seen considerable developments and advancements in treatment over the last few years. Professor Lyon is a leading voice in the specialist area, and during this webinar, he's going to share his experiences on this subject. Before I invite Richard to address us, can I remind you that continuing professional development points for the session are available from the CAA, and the contact for receiving those will be made available at the end of the webinar. So without further ado, it gives me great pleasure to introduce a good friend and colleague, Professor Richard Lyon. Richard, welcome.
David, thank you very much for the warm introduction. I'm very sorry that I couldn't be with you all in person this year. The reaches of COVID-19 have obviously been global, so hence the webinar today. Hopefully we'll be able to catch up in the near future. So thank you for the introduction. My name is Richard. I'm an emergency physician from the UK, and I'm just going to spend the next 40 minutes or so talking about the pre-hospital care of traumatic cardiac arrest. Just a small apology in advance, apart from not being with you. I have a small cold from my son. I promise you it's not COVID, so apologies for the odd cough as we go through the next 40 minutes or so. Just in the interest of complete disclosure, I have received research funding from the NIHR in the UK. I volunteer for the British Association of Immediate Care in Scotland, and I'm a member of the UK Search and Rescue Team. Thankfully not deploying today Beirut, but my thoughts are with the teams out there, and undertake consultancy work for Philips and Prometheus Medical. I'm very grateful to Philips for supporting this session. So as an emergency physician in the UK, I have a great privilege of being the Associate Medical Director of the Air Ambulance in Kent, Surrey and Sussex. Now this air ambulance covers the whole of the southeast of the UK up into the border of London, and we're pretty busy. We undertake about 2,500 missions every year, and the vast majority, about 80% of those, are major trauma. So the patient that, yes, is in the middle of this car wreck needs life-saving clinical intervention. They have had a severe injury, they're trapped, they will not survive to reach hospital unless the hospital is effectively brought to them. And this is what we're going to be talking about in this session, because traumatic cardiac arrest is the most severe presentation of a major trauma that we can face as emergency medical services. Life is truly on the line, and seconds absolutely matter if someone is going to survive. And what we're going to be going through is an approach to the management of traumatic arrest and highlighting some of the interventions, but also some of the benefits things like diagnostics and remote monitoring can bring to your care of these patients. So at KSS, we're well versed with essentially bringing ICU level care to the roadside. And I'm well aware that the audience today will be a spectrum from ambulance EMS practitioners to doctors, physicians, nurses, and everyone has a role to play, as you can see in this picture, in supporting the care of the patient. And as I mentioned, very grateful to Philips for supporting this session. We actually fly with a Tempus monitor on KSS, which is absolutely core to the physiologically monitoring of these patients. And I'm going to be demonstrating, particularly in COVID times actually, how telemedicine and advances in technology can really help revolutionize care of these patients. I'm going to show you a video next. I want you to watch very, very carefully. A little bit squeamish, maybe turn away now, but otherwise this is a true case of one of the patients that our air ambulance attended. So please watch very carefully. You can see the patient is a hit and run patient, hit at high speed, the car's driven off. He's lying on the floor. Do you think this patient is in traumatic arrest? Think he's in respiratory arrest? As EMS professionals, we've got a good idea, we should be able to judge that. How are these bystanders going to judge whether he's in TCA or not? Do you think he's breathing? Should they approach him? Should they open his airway? Should they maintain his C-spine? You can see all of these bystanders are, quite rightly, in some ways quite shocked. They don't know what happened. And this gentleman in the middle of the screen is just picking up the phone to make that first emergency call. Now, this patient was actually in a condition called traumatic brain apnea. When you hit your head hard enough, you can actually go into respiratory arrest, and if that isn't promptly managed, full-on cardiac arrest. Now, why is this important? Well, it's really important because for the first time, we recognize how difficult it is for bystanders to accurately report traumatic cardiac arrest. We've all had those calls and it's come through as hit by car, TCA, and our instinctive reaction is to think, well, they're dead. This is hopeless, it's futile. Why are we driving 20 minutes to this when we know the outcome? Well, in some of the research we've done at KSS, what we've shown is that in 50% of cases, the bystanders, like you saw in the video, get it wrong. The patient is not in traumatic cardiac arrest. They may think they are for good reasons, like we've seen, it's difficult to judge, but the patient might be either in respiratory arrest, they may just be profoundly unconscious, but they certainly have a fighting chance of survival. So in half of the cases, the reporting bystander gets it wrong. And when they get it wrong, in those half cases where they are wrong and the patient is still alive, there is nearly an 80% chance that patient will need an advanced pre-hospital intervention, such as needing an emergency airway or a blood transfusion or emergency surgery. So this paper really totally changed my view on how we should approach these patients. It's quite the opposite. They're not futile. These patients are trying to fight for their lives, and we need to aggressively get to them. And yes, of course, some will be futile, but unless we think that we are going into a survivor, then the patient will have no chance. Now, following on from that, when we arrive at a patient like this, actually, the decision-making can be made to be quite straightforward. You'll all be very familiar with the 4 H's and the 4 T's from medical resuscitation. We're instructed to think through these quickly to address the reversible causes, to try and think what has caused our patient in medical cardiac arrest to have their heart stop. Now, in trauma, actually, it's a lot more straightforward, because in trauma, there's really only 3 physiological consequences of trauma that predominantly lead to cardiac arrest: hypoxia, hypovolemia, and tension pneumothorax. So if you think about the patient in our video, actually he's got traumatic brain apnea, he's had a blunt blow to his head, he's just stunned and not breathing. He just needs someone to open that airway, maybe give a few inflation breaths, and he will pretty much spring back to life. We know that hypovolemia, bleeding, is the commonest cause of death after trauma, clearly a major issue, but tension pneumothorax is obviously there as well. Now, tamponade is in that list, and I've left it deliberately off here because it's so rare, but we will come back to it. But for the vast majority of the patients you see, addressing these are really important. And this is what led us to create something called the HOT algorithm, simultaneously addressing the reversible pathology of hypovolemia, oxygenation, and tension pneumothorax. And what we're going to do is work our way through the HOT algorithm just quite briefly to see how we can address all of the issues of HOT ideally as quickly as possible and at the same time. And having an algorithm is really important, because when you're faced with this life-death medical emergency, and obviously being in a traumatic incident, there's obviously emotional factors, there'll be bystanders, there'll be police, there'll be fire. It's a highly charged scene. So instead of having to essentially make up your decision-making as you go along, having a pre-thought out algorithm like the TCA algorithm, and there's slightly different versions of this, will really help you go through a systematic approach to the patient, not just in active TCA, but those peri-arrest TCA as well. It'll allow you to be much more effective, much more efficient, and go through the clinical interventions quickly and effectively. So what we're going to do is just take a few of the steps of these algorithms and work through it. The first is we're going to focus on the HOT part, because I think that's probably the most important. Hypovolemia, stopping bleeding. Unless bleeding is stopped pre-hospital, the chances are the patient will have just bled out by the time they arrive in hospital. And you'll be familiar with the on the floor and 4 more approach. So the bleeding can occur externally or into 4 places internally. Into the chest, into the abdomen, into the pelvis, and into the long bones. And the chest and the abdomen, there's not a lot we can do to stop internal bleeding there, but certainly pelvis and long bones there is. In terms of external bleeding, such as a major bleed like this, tourniquets, hemostatic dressings are really important. Now, it's really important to remember in your traumatic arrest patient, actually there may be little bleeding because they may have already bled out. So just because there isn't blood spurting out initially or when you arrive doesn't mean there isn't a major wound there, and you have to think about that. So early use of tourniquets, early use of hemostatic dressings to control external hemorrhage. Now, the pelvis is obviously a major source of internal blood loss. This is an open book pelvis fracture, very commonly seen, for example, in motorcyclists who have a head-on collision and hit the fuel tank of their motorbike. The vasculature of the pelvis is very large, and if you disrupt the pelvis like this, it's very easy to bleed out your entire circulating volume of 4 litres or so into the pelvis. So one of the mainstays of treating a severe pelvic fracture is to reduce the volume of the pelvis, and particularly the space that that bleeding can go into. So if you arrive on scene and the patient's been hit by the car and you see they've got splayed legs, they've got obvious bruising to the pelvis, actually the first step is just to manually hold those iliac crests and just pull that pelvis back together. You may even get a bystander to do that to immediately reduce the space. Remember, seconds are critical in reducing that volume loss. And that can obviously then be followed up by the application of a pelvic splint to hold that pelvis in place. But don't be afraid to get hands-on and just pull that pelvis together quite quickly. Similarly, long bones. It's quite easy to bleed 1.5 litres into a femoral fracture. Again, very easily within seconds, reduce that volume. Just get someone to hold onto the leg, pull the leg straight, reduce the space that the blood can go into. So you can see this almost one of the first approaches when you see a patient, that if you can see they have severely broken limbs or an open pelvis, within the first 5 seconds or so, you can instruct someone to just get hands-on and actually do a manual fracture reduction to reduce the bleeding internally. Now, as part of your HOT algorithm, actually thinking about early intravenous access is really important, because having corrected the bleeding point to the best that we can, we're going to have to restore some of that volume. And particularly if the patient is already in cardiac arrest, it's going to be very difficult for that patient to regain a ROSC without them being filled up again. Ideally, intravenous access can be used. Intravenous access is by far the most effective way of giving rapid fluid. Of course, once veins are shut down, it might be technically quite challenging, and I would say that intraosseous access is the next best tip. Personally, I like to use a yellow intraosseous needle in the humeral head, very easily placed within seconds, and of course the distance that fluid needs to travel from the humeral head directly into the heart is much shorter than putting it down in the tibia, where it has a longer distance, and some of that fluid may risk going into the bleeding point like the pelvis. Now, ideally, the patient should have blood products. It's quite common, and in days gone by, of course, flooding these patients with litres of saline would be the norm. It doesn't take rocket science to think that, of course, actually the more saline we put in, we're just going to be diluting whatever blood they have left. We're not just diluting the red cells, which are obviously important to carrying oxygen, but we'll also be diluting clotting factors. So that early administration of blood products, and that constitutes both red cells and plasma, so to carry oxygen and enable the blood to clot, is really important. And we know from military studies, particularly in the Iraq and Afghanistan conflicts, that when patients are severely injured and are hypovolemic, a 1-to-1 ratio of the red stuff to the yellow stuff is important. 1-to-1 packed cells to plasma is important. So why does that impact you as EMS providers? Well, actually having an early heads up that you might want to request enhanced medical services that carry blood products to get moving, or get moving towards them, or just getting your patient to a facility where blood products are available needs to be at the forefront of your mind. What about airway management? Essentially, we've got 2 tools in our armour to think about airway management in the traumatic arrest patient: the laryngoscope or the supraglottic airway. I would suggest that standard bag valve mask ventilation, whilst quick and easy, and certainly it will be effective, certainly from an isolated traumatic brain apnea like we saw in the video, has some limitations. It has a big limitation in it that it's going to tie up a rescuer, and it's going to tie up a rescuer, potentially 2 rescuers, because you really would need to do 2-handed bag valve mask technique to ensure that airway is painted. Much easier to put in a supraglottic, not have to worry so much about the positioning, and then even hand that airway management off to someone else to allow you to continue the critical interventions that we're talking about. If you have enough resources and scene, I think intubation is still the gold standard because it allows a sealed airway, and a lot of these patients will be at risk of aspiration or have blood in the oropharynx, and it's good to protect that. As we'll come on to with monitoring, it's also really important that you are able to look at the end tidal trace, not just to confirm airway placement, but it also gives you invaluable information about that patient's cardiovascular status. So if you intubate quickly, do so, otherwise put in a supraglottic, but certainly if you are going to intubate, it needs to be done rapidly and quickly and not distract from other interventions. So the T of our HOT algorithm is for tension pneumothorax. Now, whilst rare, these lung conditions are clearly rapidly fatal. So make your decision making easy. Don't bother trying to look for it. Don't examine the chest. Don't try to work out, is there a tension, is there not a tension? Because that's very difficult. Just treat it. Just assume it's there and put 2 needles in the second intercostal space, mid-clavicular line, on both sides. Having secured your airway, administered 100% oxygen, and decompressed the chest, it's very bandwidth liberating. There's nothing else that you can do in terms of an A and B management approach. They have the secured airway, you're giving them oxygen, and you have decompressed the tension if it's there. If there's no tension, at worst, you will introduce a very, very small pneumothorax, which will be easily treatable in hospital. So it's really no hassle at all to do it. When enhanced medical services arrive, one of the first things they will probably do is do bilateral thoracostomies. So needle has some limitations in that it can kink, it can block. An open thoracostomy and insertion of a finger allows us to definitively make sure there is no tension, put a finger into the chest cavity and make sure that the lung is up. So that is the HOT algorithm. So when we arrive on scene, the first thing we would do is think about whether they have penetrating trauma, and we'll come back to that, and we'll also come back to the medical element. We then need to think about addressing the HOT algorithm, and you can see there it says commence BLS ALS. This is probably one of the most controversial topics at the moment, is should you perform chest compressions on the traumatic cardiac arrest patient? Well, my view is that there is no easy answer to that question. My view is that you need to think about what is killing the patient. You need to think about what the pathology is, or your best guess at what the pathology is, and treat it accordingly. So let me give you a few examples. We know that compressing a heart of the hypovolemic patient where the heart is empty is not a great idea, and that you can cause damage to the myocardium by doing chest compressions. We also know that you absolutely should not delay the HOT interventions because CPR is getting in the way. So almost certainly you need to pause your chest compressions for a short period of time. I would suggest not more than 30 seconds to secure the airway, put the needles in and start splinting whatever needs splinting or put on tourniquets. You can then start the chest compressions again whilst you do things like gain IV access. Now in some cases like the hypovolemic, you may elect to pause your CPR until you've filled up the patient with blood products, for you don't want to risk hitting up and down on that empty heart. And you may be hoping the patient is in a low flow state. In other conditions, if you think about the video we saw at the beginning, that patient might have just been in what is essentially a hypoxic cardiac arrest. And once you've secured the airway, delivered some oxygen, of course he does need chest compressions to ensure that circulation is working and deliver that oxygenated blood back up to his brain to hopefully get a ROSC. So I think that is a place for chest compressions in traumatic arrest, but you just need to think about when. It's also highly likely that many of your colleagues will not be that familiar with the HOT algorithm, and it's completely normal to slip into medical algorithm mode when managing these patients. So therefore, it's important that you explain what you're doing, explain why you're having a short pause to undertake the HOT interventions so that they don't feel in some way you're going completely off-piste or they've been doing the wrong thing. Now, we mentioned medical cardiac arrest. This is really interesting because you always need to think about, has a medical cause actually led to this person's accident? Have they had an MI that's put them into VF and they've fallen off the roof? Have they had a stroke at the wheel of their car that's caused them to crash? And actually, when we did some research on this, we found that up to 20% of patients that we thought had had a traumatic cardiac arrest actually had a medical cause as the origin. So this is really important because the last thing you'd want to do is miss a patient that was just in a shockable heart rhythm and would respond quite clearly to a defibrillatory shock. So your monitoring is really, really important. And we use the Tempus monitor. We find it very practical for use on the aircraft because it's more small and light and very, very robust. So it's important that you get your monitoring on the patient as early as possible. Why is that? Well, we've already mentioned the end tidal. It's important that you confirm your airway placement and make sure you're getting a good box waveform. It's also really useful to see the end tidal value because, as you can see, if the end tidal was high, that indicates that you still have blood within your circulation, you're still perfusing your lungs, and that can give you a good indication that, for example, it's a traumatic brain apnea like we saw. If you've got a low end tidal, particularly a falling end tidal, that could be suggestive of falling cardiac output, and you might need to think about addressing the hypovolemia. And of course, we've mentioned the fact you just want to make sure what rhythm your patient is in. Again, from a prognosis point of view, the patient in PEA has a much better chance of outcome. I always say the patient in PEA is fighting to survive, and you need to find out why the patient in PEA is not having the ROSC and address the issue that's stopping it. Clearly, patients in asystole have a much worse outcome. And I just wanted to share some of our experiences how we have been using the Tempus in the management of traumatic arrest and the management of the patients like you've seen in the video. So having done some initial resuscitation, of course, you would see the physiology on the screen and you would be able to see that. And you're probably all quite familiar with telemetering bits of that information, particularly a 12-lead ECG from your ambulance or your aircraft via a cloud-based system to a hospital to see if they want to do PCI, for example. Now, one of the projects we've been running in collaboration with Philips and also supported by the European Space Agency was really exciting using something called IntelliSpace Coursing. So actually taking that data, even with patients that are in traumatic arrest or post-arrest or in a critical phase, and not just sending a 12-lead, which clearly wouldn't be really applicable to most of these patients, but actually sending a live stream of all of that data to a consultant. And we found it's very helpful, not just for major trauma, but in a whole host of conditions like you can see here. So to give you an example, when I do top cover for my air ambulance, I'll be sitting at my desk just as I am now. The phone will ring and it could be a junior crew on the helicopter that have gone to this patient that you saw in the video and are actively managing that. Now at the moment, or prior to IntelliSpace, you have quite limited information. You can see where they are on a map. That's the area we cover, the whole of the Southeast England. And you're reliant on a telephone just to get snapshot information. Also takes quite a lot of time for that crew to relay all of the observations one by one. And you're not really getting a full and detailed picture. But by live streaming the physiology from the monitor, it gives you a much clearer picture as to what's going on. So I could see that the patient already had an airway in, you can see the box waveform, you can see the end tidal, you can see the heart rhythm, you can see everything you want with just literally a couple of seconds, if that, delay for the transmission. Now, what is really important, and what is also important to you for managing a traumatic arrest patient, particularly if you get a ROSC, is to look at the trends. How often do we actually push the trend analysis screen on our monitor and see, well, where was the patient, what interventions have we done, and where are they going? Now, why would you want to do this? And why is top cover so important for this? Well, it's really, really important. So in the traumatic arrest patient, the decision making can be absolutely extreme. Clearly, end-of-life decisions will come into it. So sometimes a decision needs to be made to stop resuscitation on scene. And this can be a challenging decision. It can be very emotional, particularly if it's the child involved, for example. And it's a lot easier to support that decision to stop traumatic arrest resuscitation if you're really informed and you can see on your screen that the end tidal has been less than 1 and deteriorating for the last 20 minutes, that the patient is continuously in asystole, etc. If you saw different, you might want to give different advice. In the patient that's got a ROSC or is very temperamental, some decisions can be extremely challenging. I was involved in a case just last week where a ROSC was achieved at a traumatic arrest and the crew were about to run out of blood products they were transfusing. Should that patient just continue a drive for about an hour to a major trauma centre, knowing they may run out of blood products on the way, but arrive there and have all the specialists they needed? Or should they pit stop at a small hospital to pick up more blood, but that would delay them getting to a major trauma centre? So being able to see what interventions have been done, being able to see the physiology, and also having complete situational awareness of this patient, right down to even supporting things like intubation if you're using video laryngoscopy, right down to actually seeing the scene by taking the picture and looking at the mechanism of injury and trying to assist a crew remotely in what injuries this patient may have, can be very, very helpful. Because thankfully these cases are quite rare. Even in a busy city like London or Melbourne or Sydney, the EMS colleagues will only see a traumatic cardiac arrest probably once or twice, if that, a year. So it's really important they have access to good top cover support. So what we're finding is that this process of being there with the crew, supporting their decision making, just being able to sit back in a warmer room, not being involved emotionally at the scene, can be very helpful in making sure this patient has best care, not just during the resuscitation, but also afterwards. And what we're hopeful in the future is that we'll be able to communicate directly back to the Tempest monitor to send little messages so that we don't actually have to interrupt their resuscitation effort. We might just be able to say, you know, go to this hospital, for example, without interrupting them. Now, another question that's frequently asked about our TCA patient is, well, what about ultrasound? What about the role of hooking up an ultrasound probe to your Tempest monitor, and in the case of using something like Lumify, getting amazing views of the heart? Well, I think there is a role, and I think the role is quite important. If you look at the picture here, you can clearly see this heart is trying very hard to beat. You might say it is beating. It's beating quickly. Now, in the patient that did not have a pulse, this patient is trying very hard to survive. Their heart is trying very hard to beat. Something is stopping a pulse being generated. It might be something as simple as tension pneumothorax that just needs treated. Now, there have been few cases where blunt traumatic cardiac tamponade has now been reported. And I'll come on to the management of traumatic tamponade, but certainly a case from my colleagues in the Welsh Air Ambulance recently has really redefined our thoughts around blunt traumatic tamponade. So I think ultrasound does have a role. Now, I don't think it should be used first line. It should certainly not delay or halt algorithm interventions. It shouldn't delay all of the things we've talked about. But once resuscitation is underway, absolutely, it can be used as a tool to just help you decide what is killing my patient, what is the problem, what do I need to try and reverse. So just to hone in on that very first question a little bit more, Unfortunately, London and the southeast of England is really a knife crime hotspot, and it's not really getting any worse. We see a lot of knife crime, and we're quite familiar with dealing with the traumatic cardiac arrest patient who has been stabbed. So when you go to the trauma patient, the first question to ask is, have they had penetrating trauma to their chest or epigastrium? Essentially, any penetrating trauma to their torso. Clearly, many of you will not have the authority to do something as invasive as a resuscitative thoracotomy, but the good news is that the management is exactly the same as the hot algorithm. If you don't, you would continue to hot algorithm, secure the airway, and absolutely decompress the chest. But what you may do differently is think about, well, how can I get my patient into contact with someone that can do the thoracotomy? It might just be the scoop and run to the nearest hospital if there's one close, or it might be a rendezvous with an enhanced medical team that has been dispatched to assist you. Now, the timing of this is always very challenging because we never know exactly when they lost their cardiac output. And the vast majority of these patients will go into what's called a low flow state. So they will still be perfusing their brain for a period of time, but you may not be able to feel a pulse. So the sooner that you can get them into contact with someone that can open the chest, just in case it happens, is really important. Now, a few top tips on penetrating trauma. It's obviously a stab wound to a patient's right axilla. Now, you may think that's the base of the wound. It could be quite superficial. Some of the worst mistakes we can make are to assume we know where the tract goes, or assume we know how deep the wound goes. In London and the southeast, we're seeing all sorts of innovative ways that gangs in particular stab each other, screwdrivers being quite common, and there's actually a gang called the bicycle gang, and they're called the bicycle gang because they take bicycle spokes and they sharpen them until they're razor sharp, and they stab you with those because they can get much further reach. You can stab someone in the buttock and still reach the heart. We have had incidences, unfortunately, of stab victims being entirely unrecognized because the hold has been occluded with an ECG dot. So anytime you go to a patient that has potentially been stabbed, it's vitally important that you look all over them, especially in the armpits, in the groins, in the buttocks, to make sure you're not missing a stab wound. If they have been stabbed in the torso, the decision making should be very easy. They should be taken to a major trauma center with cardiothoracic facilities as soon as possible. Now, on HEMS, we go to lots of these patients, and of course, we very infrequently need to intervene. But the point is, in the small proportion of patients that do need an intervention, we're there and we're ready, and we can do that intervention very, very quickly because timing is everything. So I just thought, out of interest, you might want to see, well, exactly what do we do with these patients? Well, some years ago, and led by the expertise of London HEMS, we realized that how they deal with these patients in an operating theatre like this, with highly skilled cardiothoracic surgeons who have a lot of equipment, was clearly not appropriate for emergency treatment on the street. So we've honed that right down to make it pretty simple, that you need a knife and a pair of tough cuts. Now, for the patient that is in traumatic cardiac arrest with a penetrating trauma, what we are hoping for is that that patient is in cardiac tamponade. Now, there have now been cases of patients having blunt trauma and sustaining a blunt force cardiac tamponade from, for example, an atrial or ventricular rupture. And yes, you may be able to diagnose that clinically, but that is where ultrasound comes in. The decision making needs to be very quick. Could this patient have tamponade? Yes. Are they in cardiac arrest or about to be? Yes. Is the time window for intervention within about 10 minutes? Yes. We would get on and open the chest. Now, we would always do a clamshell thoracotomy. And the clamshell thoracotomy is quite simple so that we can visualize the internal anatomy. It's very difficult for non-cardiac thoracic surgeons. I'm merely an ED physician. To undertake a procedure that we're not doing on a routine basis to visualize anatomy. You can clearly see here we've got a lung, a heart, and another lung. It's very easy to identify the landmarks. This cadaveric picture shows the pericardium. So having opened up the chest by means of making a broad incision with a scalpel and then using tough cut scissors to go through the intercostal space in the sternum, I think this picture really shows actually how tough that the pericardium is. It's like leather. You can see that if you bleed into the pericardium, that is not going to be able to expand. The heart becomes entombed in blood. And this pericardial clot, well, it's not the best picture, it's like setting concrete. It will absolutely not be able to be aspirated by a needle. It's like jelly that you would eat for dessert. It needs to be manually evacuated. You'll be scooping it out with your hands to free up that space around the heart. And very often you may see patients, they have a single stab wound, one small half-inch hole that has nicked the right ventricle. Actually, very small injury has resulted in a bleed into the pericardial sac and causing tamponade. Now, these wounds might be as simple as this. You can see here, this is one single little wound to the heart that just needs, in some cases, 1 or 2 stitches. You can see there the amount of blood that comes out of the heart when that wound does not have a finger on it. But once we're into the chest, the pericardium is opened. If the patient does have a tamponade, it's actually a relatively easy fix to close off that hole. Preference is to use sutures like you have on the right, but sometimes in bigger wounds we might put in a Foley catheter to try and do it. And then it allows us to do internal cardiac massage to get the heart started again. And of course these patients are likely to need some blood products as well. Now that may seem highly aggressive and you think it's just not applicable. I think in all of our settings we have heard about cases of patients being stabbed and dying on the street, and this is their only chance of survival. The highest survival rate that has been recorded is actually up to 18%. Certainly I personally have had numerous survivors from having done this procedure, and it's not something that we should be afraid of. And a vast majority of those, it was the quick thinking interaction of the first EMS services on scene that said we need to make sure that an enhanced care team is on its way just in case this happens. So actually neurological outcome in these patients can be really good. So what about those patients that have blunt trauma and you think, well, they've bled out, they've got pelvic injuries, and you'll have heard of these case reports, or you've heard of cases where a thoracotomy is done to gain access to the aorta, to push on the aorta to try and prevent distal flow. Well, the decision making that is very, very difficult. I would say there potentially is a role for it. The survival is much lower, probably even less than 1%. This case series included patients that had had a hospital thoracotomy where you're more likely to survive. Generally speaking, these patients are high GCS, GCS 15, they may be awake and talking to you when you get there. They may be completely conscious and say, I'm not well, I'm thirsty, I feel like, my tummy's sore, my back's sore. The last patient I had like this had collapsed a paraglider chute and fallen from about 40 feet. He had an isolated severe pelvic injury, and he was absolutely talking to me when we arrived. He got worse and worse and was bleeding out. We were transfusing him, but we just weren't keeping pace with the loss. Now, in some rare cases, and I would say only in consultation, ideally with an expert top cover, should a thoracotomy be performed that would allow you to put a hand on the aorta to then stop that bleeding. And of course, in some cases, in select services like London and potentially in the near future in KSS, the use of endovascular occlusion, so something like Reboa, to occlude the aorta and internally stop the bleeding may be an option. These really are the fringes as to as what we can do. So just as we nearly wrap up then, once we have done our heart algorithm, actually the decision making becomes quite straightforward. We've addressed the things we can address. There may or may not be assistance coming. If there is, it may be worth waiting for the assistance, particularly if they can bring blood products and convert your needle chest decompressions into formal thoracostomies. Hopefully you'll gain a return of spontaneous circulation. If you don't, you're going to be thinking about end-of-life care and pronouncing that patient, again, maybe with some top cover support. If you gain a ROSC, you need to think about getting that patient to a specialist centre as soon as possible. Clearly, these are going to be the absolute sickest trauma patients that we see, and in the most cases, the ROSC could be very, very fragile and very temperamental. You may need to think about readdressing your hot algorithm. So in particular, re-needling the chest or re-fingering those thoracostomies to make sure that attention hasn't reaccumulated. And then, of course, speed is of the essence in getting that patient as fast as possible to a major trauma centre. So, ladies and gentlemen, thank you very much for your attention this afternoon, morning, evening, wherever you may be. So just to summarise an approach to the traumatic cardiac arrest patient. Know the hot algorithm. Simultaneously try and address hypertension, oxygenation and tension pneumothorax as quickly and as efficiently as possible as soon as you arrive on scene. Know about traumatic brain apnea and think about those patients that might just need some early ventilation that may gain a ROSC just by reperfusing their brain with oxygen. Don't delay intervention. So you need to ask someone to stop CPR, you may need to move the patient, but you need to go through the hot interventions as quickly as possible, ideally using a team-based approach so that several of you can work together. Don't forget to check that cardiac rhythm. Remember, 20% of patients that you think had a traumatic cause might actually have a medical cause, and you don't want to miss a VT-VF that would be amenable to a shock. Having completed the hot algorithm, do think about chest compressions. Think about what is killing your patient, what is the reversible cause. Are chest compressions going to help? Because in some cases, they might. Dispatch early to TCA. It is not futile. If you have to stand down because someone has got there and confirmed that actually the patient is futile, well, it's just a bit of wasted petrol or aviation fuel. Remember, half of the patients that we think are in TCA as reported by a bystander actually might not be, and they have a very high chance of needing critical care intervention. And lastly, just fight for the survival of your patients. 10 years ago, we used to think that all of these patients were futile. Actually, I have personal experience with numerous patients surviving from traumatic cardiac arrest. And unless we go into that positive mindset, things aren't going to change. So ladies and gentlemen, thank you very, very much for your attention, and be very happy to take any questions. Thank you.
Thank you very much, Professor Lyons. It was certainly a fascinating and interesting presentation. We do have a few very good questions that have come through on our chat box. The first one is, how much fluid would you recommend if we don't have blood products available until hospital, keeping in mind hemodilution?
Yeah, that's a really excellent question. And of course, the services that, such as mine, that are lucky enough to carry blood products, don't have the challenge of you guys, or the sort of a standard land EMS of saying, shall I give this patient crystalloid and knowingly hemodilute them? I think the key thing to that is to say, well, we need to go through the hot algorithm first. So you're going to secure the airway, you're going to decompress the chest, you've got to get some form of intraosseous access before you can obviously give that fluid. So the hope is you'll achieve a ROSC by one of your early interventions. So I think the first thing to say is, don't knee-jerk to dive in with the fluid straight away, like it might be tempting to do. We're all guilty over the years of wanting to squeeze that bag of fluid in and push it in as fast as possible, because it makes us feel better. It makes us feel like we're doing something. So I think having done the initial interventions, and then clearly these are patients that you need to think it is blood loss that has caused the TCA. And splinting, and I see there's another question we're going to come on to about splinting and reducing hemorrhage is really important. I would say then only after having done the splintage, reducing that volume that you can bleed into, would you think about the fluid. Now, if you don't have any form of blood products, it is worth trying crystalloid. you might still achieve a ROSC just by filling up the intravascular space just enough to trip the heart into beating again. So the specific answer to the question is I would give it in 250 ml aliquots, so give a 250 ml bolus and then reassess the situation. When I say reassess, obviously you're going to be clinically looking for a ROSC, but you're also going to be looking for things like a rise in your end tidal as a marker of an improvement in your cardiac output, for example, if you've got ongoing resuscitation. So 250 mils reassess, 250 mils reassess, but at the same time trying to either move the patient or get support with someone that can bring you blood products.
Thanks, Professor Lyon. The other one is to do with traction. So can you explain how applying traction to a long bone fracture reduces hemorrhage?
Sure. So this is pretty cool. This is just kind of some basic anatomy. So actually, when you have a bone, around that bone are always a lot of blood vessels, both artery and vein. And if you think about when a bone breaks and displaces, actually it stretches the periosteum. So around that bone is a sort of a film, a layer that is lining the outside of the bone. And when you break the bone, of course, that stretches that periosteum, and there's kind of a cavity within it where all the blood can accumulate. So if you have a femur in particular that breaks and offsets itself, so you've got two bits of bone, moved apart from each other, or they may even be sort of bent away from it. That periosteum is stretched, and it's stretched in a kind of like a ball, a sort of spherical type structure. So I often think of it as sort of like a melon. You've kind of got a melon space cavity in which all that blood can accumulate. Now, just the very action of pulling that bone back together into alignment just changes the shape of that ball. What you actually do is, instead of having a ball structure, you have more like a sausage structure. It's kind of oblong, because you're pulling the bones back into alignment, and the periosteum is not as stretched, it's not as taut, and it certainly doesn't have as big a volume which to bleed into. And then it's quite easy. I won't bore you with the maths, but the volume of a sausage is a lot less than the volume of a melon, just because the nature of the sphere obviously has much bigger space. So actually, just the amount of space that blood can go has been massively reduced, and therefore any extra blood that's coming out is more likely to clot. Remember, the body's very good at looking after itself. It's that blood is trying to clot, and if the volume of space around it is small, only a small amount of blood is going to get out before it starts to clot and protect itself. So take home, the volume of a sausage is smaller than the volume of a melon.
Thank you again. We've got a few more questions come through now. How do you get through the ribs with just a scalpel blade and shears?
Yeah, so excellent question. So if all goes well, we're not actually going through the ribs. So what we do is we make two thoracostomy holes, and people say, well, why do you start with that? Why don't you just open them straight up? There's kind of two reasons for it. When we do a thoracotomy, actually it is a big mental decision, clinical decision to do. So actually it's really nice to have the first step, one that is very, very familiar. So what we're doing is we're making two thoracostomy holes in about the fourth intercostal space, just anterior to the mid-axillary line. Exactly the same as we would do through a thoracostomy, and exactly the same as we would do for a chest drain. So a very, very familiar procedure. Now, there is also a small chance that when we do that, we will gain a ROSC from the release of a tension. It's a small chance, but it is there. So actually, we start off by making these two holes between the ribs. And now we've got access to the chest cavity through these holes. Then all we do is, using a pair of tough cut scissors, actually cut between the ribs. So cut through the intercostal muscles between the ribs, and we've opened up the skin using a scalpel just to allow that cut to be much smoother. So we don't have to cut through any ribs at all if it goes well. Of course, the only bit that we do need to transverse is the sternum, and we like to go straight across the sternum. And I'd say in over 90% of cases, It's quite straightforward, just with a big cut of the tough cuts to divide the sternum in one go. There are particular individuals, so certainly young, fit, healthy males with very strong bones, where just the tough cuts just won't go through. And we actually carry a jiggly saw for that purpose. So sometimes we have to pass a wire saw under the sternum, and just 2 or 3 pull backwards and forwards of that jiggly saw will open up the sternum. Now, sometimes when we essentially have not got it quite right, so we've got a 5th intercostal space and a 4th intercostal space for our thoracostomies, we end up inadvertently cutting through a rib. It's very easy to cut through a rib with some tough cuts. And this is a really interesting point for you guys. So I'm aware that many of you won't be involved in actually doing this procedure, but you may well be involved with assisting one, or you may see one for the first time. And it's really important that you have just some idea, which you have now, of how the procedure works, but also you have to be very, very careful, because a bone stick injury is a very real possibility. So a sharp bone, especially a rib that's been cut, is absolutely razor sharp, and it will go through your glove and through your skin easy as a needle will. So it's really important, if you're being asked to hold the chest open by a hem screw, for example, just take extra care that those bones can be very, very sharp, and make sure you put some swabs on it or something so you don't inadvertently give yourself a bone stick.
The next question we have here is, in an adult patient, how much blood volume would need to accumulate in the pericardium for it to have significant hemodynamic effects and ultimately result in loss of a central pulse?
Yeah, so that's a really excellent question. So obviously that's going to vary between individuals and the size of the individual and the heart anatomy, etc. Essentially, it's a very, very small volume. In most adults, just a couple of 100 mils, 200 mils of blood in your pericardium that starts to clot will absolutely cause hemodynamic effects and could lead to cardiac arrest. And in some people, that volume, might even be smaller. So in cardiac tamponade, it's really a sort of fascinating condition where, of course, by definition, you have a hole in your pericardium. It's usually a knife has come from the outside world, gone through the muscle, gone through the pericardium, and through the heart. Now, if that hole in the pericardium is too big, well, you're just going to exsanguinate. So the blood will come out of the heart, out of the hole, usually into the hemithorax, and you bleed out very, very quickly. If you get lucky and that pericardial hole is just small enough that it's not going to allow you to, exsanguinate, and it's going to contain the bleeding but cause that clot, then you have the other problem. And I think the first time you see this, the blood in there is not blood, it's like jelly, or jello, the stuff we have for dessert. It's really thick, you're scooping it out with your hands. And it just a tiny amount of blood will cause that tamponade. So much so that some of the thoracotomies I've done, when we've done it, the patient is literally arrested in front of us, and we've gone in there within about 90 seconds and just closed that hole. They've not even needed any blood transfusion top up, because they've been so incredibly stable after that tamponade has been released. So yeah, it's a very small volume that can do it indeed.
Another question here for you. Does adrenaline have a role in TCA?
So that's a really excellent question, and the jury's kind of out on that. You'll see several studies, some really big ones from Japan that have come out, kind of suggesting that it probably does not have a role. And I think my view on this comes back to that: what is killing your patient, and what do they need? I think in general terms, I don't think adrenaline does, when you say just take all TCA comers. And that's because your body will be supercharged with adrenaline already. Your body is trying its best to survive this, terrible accident. It will have tons of catecholamines knocking around. So in general, reaching for your adrenaline is probably not a good idea. Having said that, there are specific cases when I would use adrenaline. So the specific cases are when you think, for example, you have a patient with neurogenic shock. So you have a spinal cord injury and they have had profound vasodilatation as a result of that spinal cord injury. And despite fluid filling and despite resuscitation, you're not, either getting a ROSC or they're very unstable and they need a bit of squeeze. They need some peripheral vasculature squeeze. And I think sometimes in our head injured patients, the traumatic brain apnea ones, again, where you've started ventilating, you might even be doing some chest compressions and you're just not quite getting the result you want. And usually the adrenaline is the kind of, last ditch to try and get that ROSC when you've tried everything else. And you're just trying to squeeze the vasculature to get that oxygen just getting to the head and the heart. So I would put it in your kind of, when your back's up against the wall and you've just got nothing else and you really want to try it. And the other time I would sort of think about it is, if you're moving towards a hospital or you're moving to rendezvous with an enhanced care team and you're so, fragile with that patient, they may just lose the output. You've done a great job of resuscitating them, but you're still 10 minutes away. You might give some adrenaline just to see if you can tie them over to get them to the hospital, to get them to the blood product. So in general terms, no, I wouldn't use it on everyone, but in select cases, it probably does have a role.
Another question we have here, where does pharmacological interventions such as TXA come into your algorithm?
Yeah, so guys, these are brilliant questions, and this is we see a lot, and this is something that I would urge you to think about very, very strongly, because what we often see at resuscitation from TCA is a paramedic saying, I'll just go and get the TCA and run off to the ambulance and start drawing up the TXA, sorry. So TXA, tranexamic acid, as you know, shown in the CRASH-2 trial to be very, very effective in stopping death in bleeding patients. Now, the patients that were recruited into the CRASH trial were not in TCA. They were patients that, had an output, the clinician thought they were bleeding, and they were given a gram of TXA pre-hospital. Now, the risk of giving TXA whilst you're resuscitating is that it's just a distraction. That's, a clinician running off to the ambulance to get the TXA who would be much better used doing something else, getting an IV, securing an airway, etc. And there's no evidence to suggest that TXA during resuscitation, so TXA pre-ROSC, is going to, have any benefit. That the patient is in too sick a state for the TXA to kind of have meaningful intervention at that point. Of course, if you get a ROSC, you definitely want to get it, especially if, I would just give it a full stop because of the chances of them of bleeding are so high, and of course the risk of you giving it is so low. So I would absolutely have TXA in your kind of armor to treat these patients, but put it after the ROSC barrier. So say, yep, we've clocked it, we will give it if the patient gets ROSC on the way to hospital when we've got time to do other things. Focus on the hot algorithm and don't let TXA distract you from that pre-ROSC.
Another question here is, do you use fibrinogen in your emergency medicine practice?
So, I mean, I guess the broader answer is yes, especially in the hospital setting. So I guess just, it's a brilliant question just to elaborate on that. So, fibrinogen obviously gets converted to fibrin by your body, and that's what creates the meshwork of clot. So we're trying to help the body clot. We're trying to preserve that first best clot. And there's a very reasonable school of thought that says by bolstering our fibrinogen levels, we have more of the fibrin mesh around to actually build clot. And again, so it would be the same story, I think, for the during resuscitation. I don't see it yet having a commonplace during our TCA resuscitation practice. It's likely to be a post-ROSC intervention. And actually, there's some active trials in the UK right now looking at exactly this question, whether early use of fibrinogen in combination with blood products is likely to improve outcomes. So I think we're going to wait out on those trial results and see. But yeah, fibrinogen will definitely have a role in the resuscitation of your bleeding patient. But again, probably not in the pre-ROSC phase.
Okay, we do have a lot of questions coming through, so I'll get through as many as we can in the next 10 minutes or so. The next one is, in which pattern of severe pelvic fracture would a pelvic binder be potentially harmful?
That's a really good question. The quick answer is you're going to struggle to do harm with a pelvic binder if you use it correctly. So if there's suspicion about a pelvic fracture, just put the binder on. There's no problem there, and the vast majority of the time that probably won't be. Actually, the ones that have the most benefit from the pelvic binders are the ones that you're highly unlikely to miss. So they're the open book type pelvis. So where you've had a frontal impact and your pelvis is kind of sprung open, and you'll often see the patient will have, you know, splayed legs when you see them, and, you know, a wide open pelvis. So clinically quite easy to spot. And we've talked about them that you know, reduce the volume of the pelvis with your hands and put the binder on. Where it can be harmful is if you over tighten it. So if you have a very unstable pelvis, and I like to think of them as sort of broken eggs with lots of bit, and you're trying to just hold your broken egg back together. What you do not want to do is over tighten it. And if you over tighten it, you can risk compressing the bones or causing overlap and causing more disruption. So when you apply your pelvic binder, just apply it with enough pressure, whatever strap system you're using, to bring everything back to anatomical alignment, you know, firmly in place, but not overly tight in place, and not giving it all the force you can possibly muster to do that strap, because that's when you'll cause harm.
The next question is posted by Dean, a paramedic. What is the role of high fidelity training, and how often should it be practiced for maximal effect? Further, should the training be multidisciplinary, easy, that is ED staff with pre-hospital staff?
Yeah, so thanks, Dean. That's such a great question, and you know, training is something that we just don't talk about enough. You know, we've talked about this whole session, and I've kind of even hardly mentioned training. It's all the clinical aspects. Of course, to be able to do high quality resuscitation, you've got to do high quality training. Now, that can be broken down a bit. So how often? Well, I would try and do this as often as time allows. Training is always difficult. We're all busy. We're all, you know, run ragged on shifts, and many of us don't have protected training time. But actually, I think you can do low fidelity training very, very effectively. So you can just drag out your mannequin, however low fidelity. You can drag out a teddy bear if you want to, and just talk through the steps, talk through the hot algorithm, imagine yourself, you know, doing the interventions, and actually doing it with a team of people around you, especially the people you're going to be working with. So if you've got, you know, a regular paramedic partner that you run with a lot, then just grab them, you know, once a week, once a month, and just run through, say, hey, look, if we go to a TCA, you know, this is how we can do it, and just run through the steps and make sure you're familiar with it. And that's really important, and it's really important for several reasons. One, obviously, the clinical technical aspects, you want to be familiar with them, but more importantly, if you're committing much of that algorithm process to kind of automated flow, so just like a spinal reflex, what that allows is it allows you to have much more bandwidth to think, and to think about what is killing your patient. It allows you to have more bandwidth to clock the scene and work out the mechanism of injury, because you're not having to think so much about the steps you're going through. And actually, the hot algorithm lends itself very, very well to low fidelity. You don't necessarily need a, you know, a full-on high fidelity 3G SimMan type thing to do really good training. Just do it routinely. And I think the next part of the question about should it be multidisciplinary, absolutely. The more people that you can involve in this training, the better, because it's like a Formula One pit crew. There's often a lot of people involved. People have to do lots of different roles. It needs to be coordinated, and every bit of training that you can do is going to be valuable. So don't wait to be told to do it. Don't wait for your boss to say, oh, we're having a CPD day. You know, next time you're on station, and you've got a bit of downtime, just hoik out the mannequin and say, hey, if we go to this guy and he's TCA, how are we going to run it? And just work through some points, and it will definitely improve your performance.
Okay, just a couple more questions before we've got to finish off. The next one is, with humeral IO insertion, would you typically defer to the right arm due to the distance to the vena cava, or is it negligible compared to the left side?
Yeah, it's a good thought. Really good thought, Lee. Sorry, Les, my apologies. Generally speaking, it is probably negligible. So the distance between, your shoulder and your heart on left or right is really a tiny difference between the left and the right. So I wouldn't think about, choosing one for either of those reasons. Of course, that's the reason we're not putting it in the tibia, because it's a long way away and there can be venous bleeding between the tibia and the fluid returning to the central circulation. So I would put it in either. You just have a little think about your situation. So certainly in the UK, the patient's right hand side tends to be much more exposed when you're in an ambulance. They tend to sit left side up against the wall of the ambulance. So just by putting it in the patient's right, you just kind of in general have a bit better access, especially if there's someone else riding next to you, in terms of squirting fluid in. Remember, it's especially if you're giving blood products or with IO, quite often you have to pull and push with a 3-way tap and a 50 ml syringe. Just creating a bit of space around the patient just makes your life an awful lot easier. So for that reason, I tend to go for the patient's right, just for sort of logistical reasons, but from an anatomical perspective, really no big difference.
And probably the last question, we'll just see how we go for time. Can you please clarify the role of needle decompression in TCA? Is it better to do this regardless of signs?
Yeah, so the quick answer to that is yes, I would. So when you go to the TCA patient, you're not going to be able to do, well, one, they're not going to have the traditional signs. So a patient with a pulse will be able to, if they're awake, they'll tell you, I'm short of breath, I feel like I'm going to die. They point to the side of the chest that's not moving. They've got big distended neck veins, they're in cardiovascular collapse. You're not going to have any of that reference point because the patient is, in cardiac arrest. So to start in examining them and ventilating them and listening for them is too time consuming, and you just don't know whether it's there or not. So just take all of that decision making out of the way. Just treat it. Just assume it's there and treat it, because the risk of it of you doing harm by doing it is so negligible. At worst, you'll induce a tiny little pneumothorax that we can deal with or won't need any treatment whatsoever. So yeah, don't even think about sort of trying to establish if it's there or not. If you go to the patient, they're in TCA, just knee jerk, 2 needles straight in both sides of the chest. Make sure obviously you have a good listen when you put them in to see if there is an air release, because that will tell you, well, there is one there and you may need to re-needle that, or that's, you've picked up a very important part of the pathology that's caused that TCA. But yeah, I wouldn't, unless the patient has, clinical signs which you would need a ROSC for, just get on and treat it. Don't even think about it.
And there's a lot of questions coming in, but unfortunately we've just got time for one more. This one is about severe facial injuries. LMA first and quickly, or take time for an ETT?
Yeah, it's an excellent question. So again, it kind of depends on the situation. When you have a really big facial injury, a big max-fax facial injury, these are pretty rare, but you can absolutely bleed to death from a big facial injury. It's one of the most challenging pre-hospital jobs we face. Now, the treatment, the pre-hospital and the emergency treatment of a big facial injury, particularly one that's bleeding, is to pack the face using balloons called epistats. So they're kind of little plastic tubes that you put in the nostrils, and then you inflate saline balloons that inflate within the nasal cavity to temporize that bleeding. You also need some dental blocks to kind of reconstruct the facial skeleton, and you also need a C-spine collar to kind of rebuild the whole of the facial skeleton on your basement. Now, all of that is predicated on you having an ETT, an endotracheal tube in place. So a big facial injury, there's a lot of blood around, the risk of aspiration is high. If that enhanced care team rock up and they want to do facial packing, they will have to have the tube in. So I would say go for the tube, and I would just give my final little point on how to manage that. Don't be too obsessed with suction. Often the bleeding can be so kind of profuse that you can suction all day and you just won't clear the back of the oropharynx. You just can't get it dry enough to get the view. If you just do your standard intubation, but have a bit of a bigger lift with your left hand and put the blade into the vacuum, a big lift, 95% of the time you just lift the glottis out above the lake of blood that's lying there. You just lift the hole above the lake and get on and do your tube. So if you see a lot of blood in TCA, get on. I would do a tube first line. Don't bother too much about the whole suctioning. Just big lift the glottis out, get the tube in, and worry about clearing things out later.
Excellent. Thank you very much, Professor Lyon. Unfortunately, that's all we've got time for as far as questions. But there's a lot more there, certainly on the chat room. We'll try and we do have a copy of those, so we will try and send them through to Richard for some answers as well. I'd certainly like to thank you, Professor Lyon, for your time. We know it's early in the UK, so thank you very much for getting up and providing this very interesting presentation for us today. I'd also like to thank the audience. As we said, we do have an international sort of contingency here, so thank you very much for joining this. And also the Council of Ambulance Authorities. We'd like to thank them for the partnership. In these challenging times with COVID, it's very hard to deliver educational materials, so certainly doing it via webinar seems to be the way to do it in the sort of near future anyway. So thank you again for the opportunity to do that. As we said, there's a few questions about the webinar being recorded. It will be recorded and we will share after it, once it's available, and this will be emailed to you. And also, please remember you can claim your CAA points through the email address that's on the screen there for Australia and New Zealand. If you just email there, though, the certificate will be sent to you, so you can assure you've got that as well. With that, I'd like to say thank you and goodbye, and have a good evening, and thank you again very much for your attendance.